Okay, so good evening, all of you, to another session by Target MRCPCH. I'm Dr. Balaji, and I welcome also our one among another mentor, Dr. Sabari. Good evening, Dr. Sabari.
Hello, sir. Good evening.
And I welcome our successful candidates, Dr. Amruta. Good evening, Dr. Amruta.
Good evening, sir.
Good evening. And Rahul, good evening.
Good evening, sir.
Okay, so first of all, congratulations to both of you. So,
Thank you, sir.
you've done the hard
Thank
work.
you, sir.
Sincere. So far, whenever I observed, both of you have been sincere in your preparation. So I think the hard work and preparation is the key to crack this exam. And what else? I think it's time now to give your feedback to your juniors, so that the tips which helped you in crossing that success line. Okay. Dr. Sabri, you want to say anything?
So, maybe they can share their preparation time and the place of work. Because some of them have doubts that whether they are just seeing in the OPD, they are not seeing in patients. Can they be able to tackle this exam? So, share, if possible, you can share your place of work for IP or OPD, or like how do you find time and what is your preparation time? All these things will be useful to the young person. Thank you.
I'm working as an AP in one of the private medical colleges in Kerala, in Calicut actually. So we have IP, OP, ICU. So, but then, yeah, I also ended up going to the government hospital here for a couple of days, for one day actually, just to see a few of the cases that were not so common in my college. So I think I started preparing maybe just 2 months. March end is when I started preparing. May was the exam. Yeah.
But you are already seeing on a regular basis cases, no?
Yes, sir. Cases I was seeing on a regular basis.
So that adapting to the MRCPCH system, 2 months you needed, and how much preparation per day?
Sir?
Per day, how much you prepared? How much time?
Actually, for me, honestly, the classes we had was really good. That helped to keep a track on the preparation, because we did we almost covered all the non-clinical stations. So that way, I would make sure I read those topics before the class, at least that day or the previous day. That day mostly, if possible, and then the days in between where we didn't have the classes, I would finish off the clinical topics from the notes and others.
Okay. Okay. Okay, doctor. Dr. Rahul.
Yes, sir.
How was your preparation? How much time? And how was your earlier exposure?
Sir, when I started preparing, I came to Bangalore. I was doing senior residency in Kerala. At that time, I finished 1 year and came back to this Bangalore in October. After finishing all this theory parts of AKP then. And the plan was to give this year only, but unfortunately fortunately I should say, this Sri Lanka seat is the first time it was happening, and me and my friend both tried to book for Sri Lanka, but unfortunately he didn't get. So I was alone in preparation that time. So, and then initially they have put me on waiting list. After 1 week only they got the confirmation. So by March end I started, and once luckily we got that communication rapid revision that week in the April last week. So I think April first week. So me and Amrita joined same. And after our communication, we were a little bit confident. We will move through the other stations. Luckily, that time development also popped up. and we joined that. And after the communication and development, we did well. I think we are prepared well. That time we are not be confident that much, but we are going all through the theories. And after that, this last week, of April as well as the May, this video history and this basic clinical, which are the typical stations, all these we have covered in a short span and 1.5 months. I think that time in the last 2 years intensively prepared. Before that, every day at least 4 hours we tried to.
So 2-3 months means I think 4 hours you have to put in, right?
Yes, sir.
So at least we have to prepare for, and we have to keep seeing cases. The most important is the seeing cases and practicing, right? So practicing.
I'm now working in the tertiary care center, so I could see all the pediatric cases and neonatal cases I used to see. And I tried doing all these 4 minutes of rapid clinical examination in my ICU also. I tried.
Okay.
And development also I tried with 2 or 3 patients. So that was little, as much as you practice will be more confident.
Okay, so without much further delay, we will move on station wise, one by one, and then maybe we can ask others to ask their doubts and questions. Okay, Dr. Rahul, you can start. What was your first station you got?
Actually, I started with the circuit in history. And
Okay.
history, this was a 10-year-old girl child, and the history was like mother came with concerns of non-case of juvenile diabetes, this one dermatomyositis, and came with acute worsening, the sense of symptoms and swelling and proximal myopathy, all these things. Steroid toxic features were there. Their main concern was the steroid toxicity, and also intermittently taking steroids and stopping by themselves. So the non-compliance was an issue, and and this was an adolescent, around 11-year-old girl, I think. So all these headings which we are discussing in the history were very relevant, I felt. And he has discussed all the investigation part required and how initial diagnosis of JDM is going on, and also touched the treatment part with the steroids. If you are not giving steroids, what you are going to give, and all these methotrexate, IVIG, all has been discussed. And what was the excellent, what was the basic thing, physiotherapy, all these things were asked for. It was the question.
Yeah, I think Dr. Sabri is in connective tissue disorder and immunology. He can throw light on this history case of juvenile.
So, but the questions like, what are you were able to summarize the problem areas apart from the poor complaints? Like, is there anything in the past or in the family part, anything, or it is only about the presenting illness?
Social issues were there, so, and the financial things were there. They were not able to come to the hospital, and the father, I remember like that. Father was something, some issues, and so the mother only is commuting the child to the hospital. So it is little far. They want the dermatomyositis, that's rheumatologic doctor they were seeing in a long, far hospital. So such issues were also there. I felt like I have gone to all the headings which have been practiced, so I could touch all the things. So even though I have little messed with the treatment part, they have given me 9 out of 10.
I think the take-home messages in history, it is like we have to take it till the end, including all these practical difficulties, the past history, family issues. These are things they are expecting. So the whole idea is not just the diagnosis or the acute issue, but overall, what is the problems faced by the patient? That is.
And in fact, the diagnosis they gave already. There's known case of juvenile dermatomyositis.
Yes. I think the later part of the history is more important on the diagnosis known already. So in cases where it is going to be a chronic history and the diagnosis is known already, then the emphasis should be on the other part of the history, including the past and the family and
the child is also missing the schools also. So
okay.
all their concerns they will ask on like that.
Right. Okay. Thank you.
Okay, thank you. Okay, so Dr. Amrita, your history was?
So mine was I don't remember the age exactly. I think it was a 6-year-old girl who has had wetting since the past 1 or 2 months. So the history was like it was just a daytime wetting, and she's been having this issue only for the past 2 months. Before that, she was dry by day and night. So she changed schools and she missed her best friend, and she was being bullied in the new school. So it was just to show that she had a lot of social issues and bullying and all that. And they asked they expected a lot from the social history, and also a lot about the CNS history. Also, the questions I got was about if she had a spina bifida or something, would she have the presentation similar, and in what situation she would have the aneurysm. So basically, I think she meant tethering of cord. And yeah, so basically just went via the same format, and then towards the end, that is when the main chunk of the history was all the social history, and that is what they expected to differentiate from the organic causes. Then asked in detail about the organic causes, what I would rule out and all. Actually, I this was one station I did well. I got 10. So yeah.
Yeah, that's great. And they're concentrating more on the social aspects.
Yeah, so it's usually I felt like when they said it was there for 1 month only, they expected that history to be taken a lot in detail. And even when she was asking me questions, the examiner kept going back and why it is not an organic cause, what are the other things and causes. And so it was mainly to make sure that that part of the history is taken, and organic causes, if so, how to differentiate between each of it. And that part of the viva was quite brief.
Dr. Sabri, you want to ask any questions?
Again, I think the emphasis is on the non-medical part of the history. So I think for the people who are about to take the exams, the idea is you have to complete the history till the end. Take it till the end. Do not waste time fully in your present history. So try to reach till the family social history, all those travel history. Particularly if it is going to be a chronic thing. So that's what I think the key is.
She was quite happy when I mentioned about abuse and signs of abuse and things like that. And new people at
Quickly,
home.
was the age less than, it's a teenager or it is
No,
less
it was
than
not
10?
a teenager. It was just a 6 or 7-year-old. But if there were any
6 or
other
7
new people at home, new neighbors, or where she's spending time, so she happened to nod a lot and smile when I said those points. So I was assuming that was also looked for. Yeah.
Okay. Dr. Rahul, next, what you got, Doctor?
So after history, I went for the communication 2 stations. So the station was a 5-week-old baby with conjugated jaundice to explain situation of an extrahepatic biliary atresia. That was an inborn baby in the same hospital. We have counseled the mother at discharge like it is a unconjugated one. It's benign only like that. And baby came with the conjugated jaundice at 5 weeks. So that was the same case which I practiced with Harsha madam during our station 4 days. So it was good for me. Okay. Then we had to plan regarding the surgical part. Mother was crying like anything. And then she was like a little bit arguing that we have discharged the baby. You have discharged the baby. You have discharged, like that. She was keep on telling. It's like our mistake in the sense I had to say sorry in between. It's like it's not like an our error, but we had to say that it usually happens. And I had to draw a diagram regarding this all liver and all the biliary system and show her and what is the surgical that's Kasai procedure and involving pediatric surgeon, all these things, and the usual format I completed.
It was more of a information giving, right?
Yeah, information giving, definitely.
And sometimes alone, the mother was complaining that why child was discharged early.
Yeah.
So here they will
I
be.
think this decision came in 24 also. So I think that's the same scenario. So probably this is a repeat session again this year.
Okay. So can you, Dr. Shaheen is asking about, can you repeat the history topics? So maybe for the late joiners. So Dr. Rahul got a 10-year-old child who is a known case of juvenile dermatomyositis, and there were issues with compliance and steroid toxicity was there. So they were talking about the social issues where mother is alone taking for the checkups and all. And as being a teenager around the head's history and all, he elaborated. And for Dr. Amruta, it was a 6-year-old child with enuresis, secondary enuresis.
Secondary medicine.
So after daytime, it has been happening. So she was exploring the psychosocial stressors which was there in the schooling, bullying, and also discussion was also with regards to abuse and organic causes. I think the cord tethering can cause a progressive enuresis. So that was the discussion that was going on, and both have scored quite good marks. So that was good. Okay, so Dr. Rahul, so the communication was an information giving, right? So that
Yes,
was
sir.
second communication.
Second communication was neonatal hypoglycemia. That was junior has given this wrong dose of 10 ml per kg of 10% dextrose to a neonatal hypoglycemia in a preterm baby while doing the night duty. And sister has given an incident form fill, and we had to talk with the doctor that you have made it wrong. And she was arguing, and she was overconfident. She was telling, I have been working here in the NIC for the last 4 years. Nothing has been happened just like this. She used to was keep on defending, but had to say the protocols. Then the incident form already filled, so we'll have to face in the defense unit things, protections or something like that. And she was asking whether the HOD has been informed, like that was.
Okay,
And
so
she was not having any personal issues.
colleague was a colleague related
Yeah,
discussion.
yeah, sir. Yes, sir.
Was there any personal stressors or like
I asked
anything
her
of that?
personal stress. She was not having any. She was telling that I have no any issues, but little bit overwhelmed with the work because she was doing 12-hour duties back to back. Something she told.
Okay. Okay. Finally, after all the explanation, was in a mood to accept
Yeah,
and
yeah,
move on, or
yeah, yeah.
okay, that's
She,
great. Then if you're convinced it for that
yeah.
front, then it is done.
Already we have some protocol in our NICU. I will go through that. She told me like that.
Okay.
So you explained the implications of this.
Preterm, yeah, sir. Large bolus we are giving. I have told her that IVH, all these things I have discussed.
Then the implications was discussed well. And did you give solutions to
Yeah. And we have NIC protocol. We will do one seminar on base like that. Something I added on this.
Okay, so like you have to give some solutions
Yeah.
to the problems and a follow-up plan,
And
agreed follow-up timeline. So whether
yes, and adjusting the night duties like that. Something.
good. Okay, Dr. Amruta, your communications.
And you got full mark for this, doctor? Communication.
Sir.
What was your mark? Actually, you gave full mark for you.
7 and 6, sir.
Okay, very good.
Yeah, mine one station was the first station was a 4-year-old girl with the scenario they gave outside itself is 4-year-old girl developmentally normal with repeated episodes of febrile seizures, simple febrile seizure. Then examination is normal, no cafe early. Mother's very worried. So then I spoke to her about what febrile seizures were. why, what is exactly a simple seizures, or why it's like it's okay, and that she kept insisting on an MRI actually. Basically, her niece has tuberous sclerosis, and she kept wanting an MRI. So the thing is, I had to tell her that MRI is not indicated because she's still just 4 years old, and no cafe au lait, no other, nothing else, and it's all simple febrile seizures. Then I explained about so simple, complex. I mean, not the terms exactly, but why it's okay, and then about what to do in the time of a seizure. Then I told her about Midas spray, and I had to keep telling her that it's very scary to see a child sees all of that. Then there was something else also I told. Then she asked very specific questions of like what percentage of this will turn into epilepsy and all. So then I had to say like that 4% can turn. Then what's the risk of recurrence of it happening again? Then I had to end by saying that we'll wait till 5 years. After that, if it's there, we'll go see we'll take an appointment with the neurologist. I'll also consult the senior. And I also spoke to her about the prophylaxis, but it's not so common. There are not many studies to support it now like that. I think I got full, I think, in this station. So this was okay.
So it's like explaining about febrile seizures you did, and when insisting about an investigation, you have to reassure us.
Reassure, yeah, they had specifically written in the prompt in this thing outside that there are no cafe early spots. So then she kept saying my niece has something, tuberous or something. I want to take an MRI. You have to do an MRI. Like that.
So whenever someone insists to do something, you have to explore why they want to do that. I think you explored and you found out that someone, the relative has a tuberous sclerosis.
Yeah. So then I have to tell her she doesn't have any of those features for now. We'll keep her under follow up, and we'll get an appointment with the neurologist if you're insisting.
And drawbacks of MRI also you explained, right? So
yeah, yes, it's completely unnecessary. We'll have to give her sleeping medicine, all that. So that station went well actually.
yeah, good. And the next station.
Information giving with the hidden agenda.
Yeah.
Next patient was I think 12-year-old HIV positive girl. Mother is also retro positive, and they have come for a routine checkup, and the mother doesn't want to tell the daughter that she's retro positive, and you have to explain to a medical student who has like come for observing what it is, why and all. And this medical student was very hard to convince actually. She kept saying you have to tell why, and telling all that. So then I had to tell about all gray area. Mother's consent is also needed, but then she's going to be sexually active soon, so we'll have to think about the other boy also, and we'll sit with the mother and try talking to her, see if she wants to, if we can convince her to involve this daughter also in decision making and medicines and testing and all. Yeah. So
So it's an ethics scenario, right?
Yeah, ethics part.
So you explained that 4 pillars of.
Yeah, yes. I told in not like not exactly, yeah, but I told all those risk versus benefit and bigger picture and all. And then I think they told the age is 12. So then I had to say that soon she's going to be sexually active. So we can't, risk her partners not knowing. So we have to tell her at some point like that.
Good. So, Dr. Sabri, anything?
So I think the overall thing what we can take is one communication is going to be information giving, either with or without an agenda. And one is going to be a difficult colleague or something, a difficult scenario like this HIV ethics and all those things. This is what the crux is. I think most of the years they have following this pattern of one easy and one frustration.
Yeah. And And here in the medical student, some amount of jargon is acceptable, but when it comes to the patient, we should avoid the jargon. So that is important. Okay. And okay, so Dr. Rahul, after communication.
After communications, video stations were there, and first video was an wheezing of the 18-month-old baby. So they expected viral-induced wheeze. So first DD I could say that, and along with that, early onset asthma, all this bronchiolitis, typical or not, but all that DDs and history, examination, everything, sir. And investigations, they wanted the treatment for less than 5 years. How you're going to manage the asthma? Like,
Okay. So
that was okay.
how did you pick up wheezing in the child? So is there any sounds were there or?
Sounds were there, sir. Audio was there and it was well clear.
Okay.
And
so how you prepare the video station by writing the differential diagnosis, right? To start.
yeah, sir, exactly. And I made a few notes after seeing all these DDs, initial for headings, and made some DDs. And I read all these investigations and management part separately. So we have practiced that stations well. Not it was good only.
Good. Then second video.
Second video was initially was showing swelling over the face and means periorbital edema, renal edema like that. And they were also looking at the lower limbs for pitting pedal edema also they were showing. And they were asking the DDs of edema. So So they expected nephrotic syndrome, sir, and they asked questions regarding that.
So how did you arrive at nephrotic syndrome? Like, did the examiner say that there is proteinuria or final?
No, nothing, sir. Only sound. Only this video was there. No added questions were there. Only just showed this facial edema as well as the lower limb pitting pedal edema. So had to give all the DDs for the edemas, for the generalized edemas. So out of that, if it is nephrotic, then he asked like that.
Okay. So while investigation part, so he went to the investigation. At that time, he told the nephrotic, right?
Yes, sir. Yes. All DDs I had to say, even including all these insect bite, angioedema, all these I had to all. This liver, cardiac malnutrition, all these we have to.
And after that, how were the questions? Were they from the pediatric guidelines?
Yeah, definitely, sir. How we are going to manage first episode nephrotic syndrome? How what are investigations, and how we are going to manage relapse? All these things.
So I think that is the clue for the video station. So most of the videos are repetition, so they keep coming again.
Yes, sir.
The same theme.
Yeah. The better we have to prepare the DDs and go through the guidelines better.
Yeah, and prepare from the guidelines. So most of the questions will be from the guidelines, the nephrotic. Yeah. And is it the standard questions they have been asking? How will you, what history, what examination and investigation?
Yes, sir, exactly. What we have discussed now, that same thing has been followed. I have gone through the videos. Yeah, same only.
Okay, good. Dr. Amruta,
yes,
your video station.
Mine, one was laryngomalacia, 3-week-old, 3 week or 1 month, I don't remember exactly. Child with spider, and then the DDs. If it's a well child, sick child, how you'll proceed, what advice will you give the mother. Then there was something like specific he asked, as in what would it be if this child was not thriving properly? What other DDs you will think of if it was not a particularly well child? But yeah, by then actually my time got done. So
okay.
Then the second station was the scenario given was a 2-day-old or 24-hour-old baby with a saturation of 85% even after giving 100% of oxygen. And then the video they showed was again a baby. You can't really make out the cyanosis, but the pulse oximetry meter showing this 85 or less than 85%. And then with this thing which was kept on all 4 areas of the heart, I mean the auscultatory areas, and you could hear a murmur. So then the DDs, why not PPH and why CCHD, blah, 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 all the DDs, how you differentiate. Then asked about if it is CCHD, what would you manage? So prostaglandin, then side effects of prostaglandin. Then he was looking for the answer of referral also. Referral to tertiary center with cardiothoracic unit, like that.
So
the differential cyanosis or yeah, just focus on one main cyanosis.
No, there was no difference. They did not show the differential cyanosis
Not
actually.
so.
Yeah, just that. It was mainly the heart sounds which you could hear.
Cyanotic
Hear
heart
a
disease.
murmur and this thing. Yeah, cyanotic heart disease. So just the different DDs, what all we present like that. This basic stuff.
Okay, so I think this also from the neonatal guidelines, right? So you will have if you go through the neonatal guidelines, there will be how will you manage prostaglandin.
Yes, sir.
Some results on. Can you mute your mic?
Okay. Okay, Doctor. Dr. Rahul, next.
Next were the clinical stations, sir. First I went here CVS station, and the Piyush sir was sitting, I don't know. And first he asked me to, this is a 14-year-old child, boy, and he has come with fever. He used to have fever from fever episodes from childhood, and just examine and tell me like that. So when I started examining the CVS system and from head to foot, all these, it was like a CHD only, no a cyanotic thing. And head to foot was nothing, no scars or something. And after auscultation, got it as a full pansystolic murmur with a loud P2, I suspected. So initially, I thought it was a VSD with the pulmonary hypertension, but a 14-year-old rare without isomerization. So then I thought of fever and told rheumatic heart disease, Korea MR, because the murmur which was pansystolic was loud, and I could get a loud P2 also. So it was a little bit confusing initially. So I said as all DDs like that, and he was not happy at that time. And he asked general things about the CVS and investigations, X-ray, CG, and all these advices what you're going to give in common cases. So
Okay, so
since infancy, not since birth, somebody's asking.
so it's like a 14-year-old child with a systolic murmur, pansystolic murmur. Actually, even I got a similar case where it will be heard on almost both
It's
areas.
a very difficult. 2 minutes only he gave. I think less than 2 minutes only he gave me, and he has started asking in between examination also. So I was little tense that station, and like that got all messed up. And he gave only 3 out of 8.
Yeah. But I think if we are not sure, having a differential diagnosis is fine. Pansystolic murmur, I think VSD and mitral regurgitation both are good equal differential diagnosis. Maybe if there is any radiation to the axilla, anything like that you got.
Nothing, sir. I initially I thought of the RHD, but the radiation part was higher. So I put VSD and pulmonary hypertension, but I again said there is no 14-year-old. It is rare like that. I also got like little doubt there. So he didn't ask more about the DDs, and he directly go through the investigation. What are you going to do like that?
Okay. Okay. So it depends upon the examiner. So I think the clinical station is about always about two things. I think one is the patient. The variability is always there. And second is the examiners. Examiners have their own choices. And that's why we have 10 stations. Okay. Yeah.
So you were, are you giving a running commentary while examining, or like you were around 6 minutes of?
He started as running commentary, but he said you examine, and within 1 minute he said it's finished. No, like that he asked and started asking. So I couldn't examine more.
Okay.
And,
But neither. Okay.
I don't know.
Okay.
The
And
good thing is that I got that pansystolic murmur. That's the only thing. So I put on DDs that will.
Okay.
yeah, Dr. Shine is asking fever since birth. No, I think it's on and off.
It's regarding childhood something he started. Also.
And what was the diagnosis afterwards? You would have got some clue, no? You would have.
No, sir. I would discuss with the fellow colleagues and fellow examiners, candidates, and they were sending the same VSD with the pulmonary hypertension, something.
Okay. And actually, Dr. Shine is asking of the marks. Actually, the examiner scored him a bit less, 3 out of 8 only he got. Okay. Dr. Amruta, your CVS case?
Mine was again, I don't remember the age exactly. I think it was a 9 or 10-year-old boy. And they just told, do the cardiovascular system. He's presenting with dyspnea now, and he had a median sternotomy scar, and second pulmonary PS murmur was there. And then Viva was again, he gave me some 2-3 minutes to examine, but then after that he started asking a lot of questions, and I could answer few. One question which I remember, which I didn't answer, was he kept asking, what are the tests will you do for finding out, for dyspnea? What test will you do for dyspnea? So that I didn't exactly know what he meant. And by the time my time also got over. So just median.
What was the
There
main
was
diagnosis you kept?
TOF post surgery or any complex heart disease post surgery. So
Yeah.
that part was that he seemed to accept. But after that, there were like a couple of questions I didn't answer. One of this I remember was this, what exactly. So I didn't know if he meant a CT or what exactly he meant. By what will you do to know what dyspnea it is? And then after the exam, I thought whether I had forgotten the PR part, the regurgitation part. But then when I spoke to one of the candidates, she had said PSPR, and he didn't accept the pulmonary regurgitation part. So then I don't know what the finer details were.
Yeah. But I think it's acceptable when you have a median sternotomy scar with pulmonary stenosis. I think the tetralogy of Fallot is a good differential. But clubbing and cyanosis was not there. Huh?
No clubbing, no cyanosis, no sir. And
So
child seemed to be quite well grown also.
So after correction, the child would have got better.
Better, yeah.
Hyperoxia. So which test? I think we are not sure. So.
But it was for the older child. I don't think you will do the hyperoxia for the older child.
We usually go with chest X-ray, ECG, echocardiogram.
Yeah, I said all that, chest X-ray, ECG, echo. Then I don't know if he meant the treadmill thing, but I don't know if you do that in small children. So I didn't say that. I thought of it, but I didn't say it because it seemed a little absurd. Then I don't know whether he
Was the issue of dyspnea, was it acute?
Actually, it was. He said he meant it like it was an acute, like he has presented to you with dyspnea. Now, so I was
the
not.
discussion going with infective endocarditis, something like that?
Oh, maybe that's what he meant. I didn't. I mentioned infective endocarditis elsewhere, not for this specific thing. But echo was mentioned again. Maybe he meant cultures, I don't know. But he didn't give any history of fever or nothing else. Just this dyspnea. So then I'm not sure what he meant.
I think what examiner is wanting.
Yeah, some few questions it's little hard because you barely get time to process what the case is. Between when some very specific questions are put, you don't get time, and then I think they want to check if you know all the domains, so they don't give you much time to think. So they'll be like, okay, it's okay, and then they go to the next question, and then somebody will come and knock them with
3 minutes. Hardly 3 minutes. So in the 3 minutes, we have to summarize And
just,
they have to tell
yeah, and they have to see if you know the investigations, the treatment, etc. And then by the time, invariably, there'll be a knock on the door.
Okay. So, Dr. Rahul, next clinical station.
Next was a 7-year-old girl, sir, with hemolytic facies were there, and pallor very difficult to identify. That a little more darker room was that, and also icterus I was not sure, and there was a moderate hepatosplenomegaly, and she was asking the causes, how you're going to manage if it is a case of hereditary spherocytosis, like that, and even then what all that transfusion, how you're going to give. If it is a thalassemia, also she asked. All these investigation part, peripheral blood smear, all these things she was asking. And that was okay, sir. But okay only.
Was
But
there
now
multiple Venflon marks, or were you able to
sir,
make multiple Venflon marks?
I didn't hear, sir.
Did the patient have multiple Venflon marks, venipuncture marks?
No,
No.
no, sir. There was not. Actually, I didn't see
Okay.
anything
Right.
much.
I think thalassemia is a standard question in the abdomen very often,
Yes, sir.
because it's very common in Indian setup.
Yeah.
Blood transfusion, they keep coming regularly to the hospital. So thalassemia should be in your mind. And well transfused, I think, as you say, pallor and icterus might not be that significant. As such,
Yeah.
thalassemia, the icterus will not be that much. But
Mhm.
spherocytosis, icterus should be very prominent, actually.
Yeah. But this was a dark pallor also was very difficult. I just said it just only like pallor was
That is
present.
always there, no? In an examination hall, in that light, tube light, sometimes it's difficult to appreciate this. But based on the hemolytic phases, based on the
Yeah,
stent.
The facies was evident.
Okay, doctor. Doctor,
Yes.
your abdomen was?
Mine was a 9-year-old girl with a massive splenomegaly. She had mild jaundice and very like massive splenomegaly reaching almost till the umbilicus. And after examining, and I told my findings, told this thing, and she gave me the tape and wanted me to measure also both the liver and
Same to me also.
yeah. So then the DD's investigations management liver, actually it was there, but seemed like it was a bit shrunken. So then I kept CLD, and then other things also like malignancy, storage, all that didn't seem to really have hemotic phases actually. So then same management, what do you do? Investigations, what other I said some few things, but she wanted more DDs, more investigations, I think.
Okay, so what was it like?
So I think everybody whoever I spoke to gave like different DDs, like CLD, same thing. She just asked the DDs specifically, like what all will you do investigation. So this first massive splenomegaly, whatever normal DDs I gave. Like it could be the malignancy or hemolytic, this thing, anemia or CLD because of the mild jaundice. So that she seems to be okay with it.
Okay, doctor. So as a DD for splenomegaly. So when
Yeah.
we're not very sure, so we can give as a whole the splenomegaly difference.
Splenomegaly DDs.
I think the portal hypertension also can be given.
Yeah, HPO.
Okay, okay, doctor. Dr. Rahul, next question was?
Next station, the CNS station, was a gait abnormality. It was difficult once. Initially, I thought it was like this one painful limb only. Then when I asked him to turn back, and I got it as circumflexion, and told it as hemiplegic gait. 7-year-old boy. So the examiner asked me to do the lower limb examination, CNS one. So and after I gave the findings and including the contractures, and initially he was not willing to accept the contracture is present. It's just a holding out. And he asked the other examiner to examine the child and say whether there is contracture, and he told there is contracture. And then he told me very good.
Okay.
Then two important therapies he asked what I'm going to do with this child, and there's physiotherapy and OT roles, occupational therapy roles he asked. Then he asked about the causes of stroke in this one, hemiplegic stroke, like embolism, infection, all this.
And you are able to demonstrate the increased reflexes.
Yes,
Plan.
sir. All this examination, yeah. Lower limb examination, tone, power, reflex, everything you had to. Clonus also you have to check. I show them. And he was happy and got
So
full
if,
marks in that.
if it was a lower limb, so then upper limb you were not able to.
Yeah, yes, sir. Actually, this station enough time was there. So I after lower limb, I just looked at the upper limb and same pattern, hemiplegic only. So and also the cranial nerves initial also I have checked that. Just facial and this all opening in the mouth and see the 9, 10, 11. So that time the started asking questions.
So once you finish, if you have time, even if the task is lower limb, I think you can ask permission and look into the upper.
Yeah, definitely.
Otherwise, hemiplegia will be difficult to pick up only by examining the
Yes,
lower limb.
How was the mentation, the child? Normal.
normal.
Okay, so Dr. Amrita, your CNS case?
Yeah, actually, my CNS case was a little hard for me to pick up. I think in Singapore because the physio is so good. It was supposed to be hemiplegia case, and basically there was not much tone difference or even hypotonia that I could pick up. Power was almost 5/5 when I tried checking. The only thing was the gait, little bit of there was a gait abnormality, and the reflexes were brisk. But other than that, I think maybe because it was Singapore, it was very hard to pick up the tone difference. But then I said upper motor neuron. I got a little confused whether it was a diplegia or a hemiplegia. Because I didn't make out any tone difference between both the limbs, and then finally, so then I said hemiplegia, and it ended up being hemiplegia only. But I was marked down on the station. This was my worst station.
How was the
Okay.
plantar?
For the others, a few of them.
Plantar response.
Plantar was actually equivocal. I mean, as in it was, and I asked the others also, so they didn't get any. It was not an extensor plantar. The only thing was knee jerk was brisk, and then the gait was a little abnormal. These were the only two
Mentation
clues.
was normal. Mentation side
was
of
yeah. He was listening to. I mean, it was almost normal. So
I would say the CNS station is always like CNS and others.
Yeah, and it was so confusing. I got so confused first. Like the thing is, here you're used to seeing children with, like, when you see them a mile away, you'll be able to understand it's CP, spastic, or what. This power was so good. Tone, I couldn't make out a difference. Bulk was so good. Then I got confused whether there was some calf muscle hypertrophy also, because the bulk was that good. But then it was a UMN thing somehow. Like I said UMN hemiplegia, but she was not very convinced. So I got marked down the station.
Okay. Dr. Rahul, next station.
Next station was a short stature, general examination and manuals they asked. So it was a little bit easy for me. And this was 10-year-old girl, very short for the age. So initial anthropometric measures, just comparing with the parents, MPH, all this I had told. And this was a running commentary. He liked that also. So I performed all the manuals live and was happy. And after that, head to food examination with the relevant systemic examination also. So he was asking why you are looking into the chest, why you are looking into series, all these. So Turners, I could say it was little bit one or two features of the Turners. I felt like this one, the nipples were a little wider, and also that neck backs little was there. So then he asked about the investigation management, how you going to do what all karyotype, including all these and indications of growth hormone and growth hormone therapy, like that he was asking. At that time, the time got finished.
Okay, the child was not dysmorphic.
Not dysmorphic, sir. Faces were normal only, just
And
only find
thin built or
very thin, sir.
very thin.
thin. Initially, I thought some systemic illness or chronic illness, like so. DD with the DDs only, I explained all the things.
Okay. And did you measure the height and upper
No,
section?
no, sir. Nothing was there. Time was also not. I told that I will do like this. I will measure height, and for mother was also there. Since the father is not available, I will go for the MPH like that. I had to tell. So just to tell them that this is the
STEM was,
practice.
they said that the child is a known case of short stature, or they
Nothing, sir,
want to
nothing.
just examine?
Just examine how do you feel. How do you feel the approach? He told that 10 year or 9 years, so it was looking short for me, like that.
But he didn't give that the child is short, right?
No, sir. He didn't give anything like that.
Okay. So there only the problem actually. So when they say do a general examination,
Yeah. You do a general examination.
you have to first interpret that the child is short. So how did
So
you
yeah.
pick up by looking itself? You were able to identify whether
Yeah,
it's
looking a very short for the 10-year-old means little more length, I felt. So initially by looking at the short stature, man was only, but everything is symmetric only. But so initially I thought of it's a Turner, but I was looking for the Turner features, but only this one was identified then. So
I
Any
think
female child with short stature, Turner should be
should
yeah,
be there.
the
first,
top three differentials.
yeah,
And once you do the maneuvers, they will be very happy actually. So they give
yeah.
a lot of measurements. And did you do the measurement? That's what Dr. Rahul was saying. He didn't have time to do the measurements, but they accepted. And even the instruments were not there. No? You said
No,
like,
sir, nothing is there. Just examine the child, do a general examination was the comment. So I started with the general examination and manuals. At last only I told that for the evaluation purpose, we have to take all these mother, father, MPH, all these things. So just
suppose,
verbally only told.
suppose there is a tape and kept, then I think you should do at least at the end.
Yeah, sir.
Start doing. Okay, that's good.
So that in very short span of time, sir, we have got to do so many things. I don't think we will get time in usual
Measuring
things.
will be difficult only.
Yeah. I
Sometimes
don't know how much we.
our Indian examiners sometimes expect for a short stature you don't even measure like that. So at least you once you finish off your general examination, systemic examination, try to measure the height if there is a stadiometer. You need not
Yeah.
complete it, but it should not like you ignore it. So you should say you are trying to do, and while doing, the time might get over. So at least the examiner will be convinced. Okay, he is trying to measure. Okay, so that is the thing. And Dr. Amruta, your other station was?
Yeah, mine, the thing given was it's a 10 or 11-year-old boy with a cyanotic heart disease. He's a known case of a cyanotic heart disease. Now and he also has a chronic lung disease through the examination. So on examination on the right side, there was the entry was less, dull note on percussion, then cyanosis clubbing, all that was there. And basically dull note on percussion. So he kept asking me what DDs it was. So first I said lobectomy and all that. Then they asked me about a scar, but there was just a small scar, maybe not enough for the lobectomy. There were some dilated veins. Then I said aplasia, agenesis, hypoplasia. Then that he seemed to, okay, he was still this thing. But it took me a few, like maybe 20 seconds of prompting to reach an aplasia, hypoplasia, because I kept saying agenesis. And then he asked me management DDs, other DDs, and then time goes up. But I gave the exam in the Singapore University there, and it was also an MD exam for the students of the same university. It was an MD come MRCPCH exam. So they are the ones who told me this is a case that comes to their OPD. It says Schmitter syndrome. But I don't think you can identify Schmitter. Yeah. So I don't know. I would never have been able to identify that otherwise. So I just told what my findings were. I think that was okay.
Okay. Dr. Pankaj is asking any interruption. I think there is no interruption. But the question is like, what was the
Clinical
command?
findings, yeah, whether you're able to pick.
What was the command? Which
Comment was it's a boy with a he's a known case of a cyanotic heart disease. Now, and he has a chronic lung disease. Do the respiratory system examination.
So RS examination.
Yeah.
So you did the RS examination, you did the inspection and
Yeah, inspection, all that, palpation. So the findings, I think what I found were almost okay.
so
Only my
you got
DDs I fumbled a little. Yeah.
so you got the decreased air entry on
Yeah,
that?
yeah, that was clear. Air entry was decreased, then very dull note. All that was clear. So then again, I
we
didn't
can
think.
have a congenital heart disease with the congenital malformation, something of that definition.
Pardon, sir?
So probably the difference we were expecting was congenital heart disease with the congenital lung malformation or
I said
something
CCAM
related to.
actually. I said CCAM and this thing. So he was not
Yes,
happy.
yes.
He said, "Are you sure it is CCAM? Then won't they do surgery? Won't there be a bigger scar?" So he kept.
Bigger
I kept going around in circles of the different DDs
difference.
for a good 30 seconds because I was not expecting. Then I kept saying, "No, it's not cystic fibrosis or anything because of the lung. This thing, he doesn't look like that." So I kept saying, "This is." So I mean, the scenarios that we know in RS, what they keep, I kept saying it's not this, it's not that because of this. So he kept nodding, yeah, okay, then what else? Then what else? So then finally I reached some agencies, I could say, yeah.
Sometimes they will keep tough cases.
Yeah. And since I think I was writing it with the students of that university also, I felt like maybe somewhere, yeah.
I think what we can do is our findings. So
Yeah, so if you get the findings right, they are half okay. Like they're like, okay, fine, then it's fine.
do your systematic examination.
Yeah.
Systematically get your findings right and try your best to give a differential diagnosis.
Yeah. Actually, out of 4 clinical, I think 1 or 2 stations they'll keep hard. Other 2 stations will be little easy.
So definitely 1 or 2. That's what this others and the CNS will always be a challenge.
Be hard, yeah.
Come
In
and-
India, I think CNS still it would be a little easier for us because we're used to seeing these type of cases.
Yeah. Mostly cerebral palsy they will be keeping.
Palsy, yeah.
Okay.
So I
One
think it was
important
pulmonary
clue for
hypoplasia. I think that was a diagnosis because when I said that he said okay, and then he moved on to the next question.
So pulmonary hypoplasia.
Yeah. And you could see dilated veins also, but at that time it was like a bit, I kept wondering what is this over here.
Yeah. Okay. So next, Dr. Rahul.
And next session was a development, sir, last one. And it was a 2-year-old girl child. They had a concern of speech and language as well as social cognition delay. So this was onset after 18 months, like had an episode of this infection meningitis and post-meningitis. As a part of post-meningitis sequelae only, this autistic features came out. So the history was okay, and examination wise the developmental age was like very less than 1 year. That was the problem. So since it's a 2-year-old child, after 18 months only this meningitis came. So the expressive as well as the receptive are different language. The developmental age was around 1.1.5 just. So and the social was less than very much less, and she was not even looking at us and was not cooperative to do any of the things which we have learned. No, we can't do anything. She was not looking at me. She keep on telling that this child is not looking at you, not looking at you. So there was nothing to perform. That was the problem. So then one mistake from my part was the history. During history, this post meningitic Bera I didn't ask in history. Post investigation only I told. So she was keep on telling that you didn't ask in history about Bera like. And the discussion came out with this one autism. What is how you're going to manage? What is the role of the speech and language therapist? And autistic, all these features. Everything was asking about autism.
In your final diagnosis, you are able to say that it's probably autism because the lack of eye contact.
Yes, sir. She was asking what diagnosis. What I initially thought is a post meningitis sequelae and cognition delay. Also, and what condition you are going to like that. She had to push once, so I told it is autism like that. Then started about everything about autism, and she was what investigation next. She was asking. I was thinking, and last finally the time got over, and I asked her what answer you were explaining. She was telling metabolic screening.
Okay.
Okay, that's and that was that much only.
So
The thing is that we have to get practice with less than 1 year, little more. I thought at that time. That's most of the things we used to keep the age was 3 or 4, and we keep on discussing all the milestones at more than 1 year. So less than 1 year we had done, but it was a little more practice was required, I think.
Dr. Pankaj will agree. Actually, yesterday also we were doing infant development only.
Yeah.
So this how much they gave actually?
9, sir. 9 out of 12.
It's acceptable, I think.
Mm-mm.
Had we,
Everyone was unhappy with that station. All the candidates.
it's tough actually. So once less than 1 year, and that too, the child is not cooperating anything, no. But were you able to perform all the tasks in the order, or
Yeah. I was asking all the tasks from in a descending order, in the sense was from 2 years to down. I was asking less than 1 year. Also, she was not happy. That I had to reach up to 6 months, I think, in social. So it is was to take consuming time, and we are not reaching anywhere. So like that, this was a problem.
okay. So Dr. Amruta, your case.
Mine, they told it was a 4-year-old. The question was a 4-year-old child with speech delay, and then and then they gave a picture, which at first I couldn't understand what it was, and then finally I understood it was a Beckett treatment. A little bit of it was not so clear, hemihypertrophy and some malformed ear thing. So that was not so clear. But then from the history, newborn history, there was a lot to take. There's a hypoglycemia history, then there was some seizure history, then surgery in the first few days for omphalocele. Then there was one more surgery, which I forgot what exactly, but and then the seizure history. It was you have to talk to the grandmother, and then there were also some social histories, and basically it was a child with GDD. So we wanted to know why Beckett-Friedman would have GDD, how I reached the diagnosis of Beckett-Friedman. He was not very interested in the syndrome name as such, but more of by GDD and all of that. Then actually all the toys, it was a table full of toys and things, and at that moment to pick out the things was a bit like, okay, I had to keep searching a bit. And if I asked the examiner, he was not agreeing. Like, he wanted me to simulate the whole, like properly simulate and do action and all of that. So yeah, but then questions were again about what is normal developmental distinct questions only. But
What was the domain they asked?
language and this thing, what, cognition,
So,
yeah.
so
And I had to ask about autism also. We asked about autism and all also.
So hypoglycemia and syndromic as a
yeah, and with so many parts in the history and some features of autism, some then the newborn history itself took some time because he had so many things. He was on medication, surgeries, all of that.
And while examining, the child cooperated.
Yeah, examination, the child was cooperative actually.
Okay.
Yeah.
So the examiner was like while picking up the toys, he was making that issue. Then he
No, actually, I kept looking at him and I kept talking. Then he kept telling me, no, pick it up and show, like that. So then I picked it up, and so like that some time went. So maybe that's why I got. Actually, I thought I did well, but he didn't give me that many marks actually.
Okay.
So
Okay.
yeah.
And he expected you to simulate fully.
Yeah, completely. Not like whenever I say, then I'll ask him to do this. No, so you ask him. That was what he kept telling me. So
Okay.
maybe when I saw the table full of toys, I should have thought and started automatically gone into that way of doing things.
Okay.
Yeah.
And but social, it's difficult to fully simulate, no? So that he accepted, or
Yeah, the FDP case part he was okay, but then there was spoons, cups, all of that kept. So I had to pick that up. Nice. Yeah, it was a table full of toys and things. So in that thing, he'll keep asking you what to do next, what to do next. So you have to like pick out the things. That was a bit stressful.
okay, okay, yeah. Yeah, Singapore is famous for that. They suddenly in one table they will keep all the instruments. So
Yeah.
I remember in the CNS they did that. So they kept all the instruments.
Yeah. Actually, the students there came with so many instruments. And seeing that initially, I freaked out thinking you had to bring things, but then that was okay. Nobody took anything inside. And in some places like this development station, I found it. And the examiner also, he was a bit like a little old examiner. So he was not accepting a lot of things you're saying. He'll just look
Yeah,
very unpleased or
yeah. So that's what. So we. But something strange actually. They show you a picture?
Yeah, they showed a picture. So I think that is there on the MRCPCH website. I'm not sure. There, it was one picture of a face or hand or something. Face and it was not at all obvious actually.
Because
Like I didn't understand.
usually in development they don't show pictures.
Yeah, it was face and ear, and I didn't understand what it was. I was thinking it could be some syndrome, but when I heard the history, I was like, okay, fine, this makes sense. The grandmother kept saying, talking about seizures and all, maybe like they had told her to give some clues and hypoglycemia and all.
I think which website? I think is
No,
it.
I see. I don't know if they've taken it from the RPCH. If there are some pictures, I was thinking because under that this thing, it was they had written some RPCH something and picture number and all. So I was thinking whether they have such things on their website as a study material, and if I have not seen it, so I
No, no,
got
no. So
confused.
they usually have their own library. So
Library, maybe.
they
But
don't.
from the picture, it was very difficult. And seeing the picture outside the development station will initially make you a bit tense because you won't even understand what it is. And when they give pictures, you know that they mean something very specific, but you don't even understand what it is.
So like then we can just say syndromic child.
Yeah.
We're not sure. We can go with and try to give hypoglycemia is there. So as you
Yeah.
say, liquid white man. Was
Yeah.
this an actual child? No,
No,
this
there
was
was no
an
actual
actual
child.
child. The
And yeah, my
picture.
center was in Singapore. Yeah.
So now the questions are open. I think we have finished all the stations. You know, the question is open for others. They can ask the doubts. You can ask your doubts. Anybody
And then
have?
I really want to add that even though I didn't do so well in the clinical stations, I actually passed because I got really good marks in the other stations. Except development, all the other stations were almost full or maybe just 1 mark down. So it was only because of the practice we did that I passed.
Yeah. So I think that is a very important take home actually. So when we were discussing that only, so in Singapore cases are going to be tough. So at least we have to prepare ourselves the communication, the video station, then the history station we will practice so that we will have adequate buffer for the clinical station. Assuming that one or two stations are going to be definitely tough clinical station because we don't have the option of seeing all the variety of cases. So many cases we might have not seen. So the better is to prepare and be ready to score more marks so that this uncertainty of clinical cases, na, so you have a buffer of 20 marks. So that will help you cross the line. Okay.
Yeah, so if you like aim for an average or at least slightly above average for your clinical stations and do really well in your if you're able to do well. I mean, clinically, you really don't know how it goes. That's what I understood. Some stations were so hard and confusing. And at that time, like when you hear the questions and when you read the recalls, it's different. You'll be like, okay, yeah, hemiplegia or yeah, CP. But when you're there and you get only 2 or 3 minutes to examine with somebody staring at you when you're doing everything, it's different.
Yeah. So any doubts are there? Okay,
Sir, I have one question regarding that CVS station, which Dr. Rahul has talked about, that pansystolic murmur. So my question is that why don't they consider putting a DDs like VSD and MR? Do they specifically mark him down because he is not able to reach to the diagnosis?
So
I-
it is the Dr. Rahul, you can.
I think we have to put up all the findings first, and then if we are not able to arrive at the one Pakka DD, then we can go for multiple DDs with our priorities. I think he expected MR with RHD as first. I think I told us VSD with pulmonary hypertension, even though, but that time only he got irritated like that. I felt, and he moved to the other questions like that. So
Actually, Dr. Shain, for me, actually, my examiner, I got the same issue, a bigger child with a pansystolic murmur. So I gave the DD. The examiner accepted actually. He in fact said, if it is VSD, how will you investigate and manage? If it is MR, how are you going to investigate and manage? So like that. So I think it depends on the examiner. Clinical stations depend on the examiner. Don't go by a set pattern of expectation. So each examiner will have their own way of marking. So I would say that
I think the two Indian examiners were little tough. All other examiners were very good, I felt.
you have to better catch the pulse, what they are expecting, and try to adapt. So that is the thing.
Okay, all right. Thank you so much and congratulations.
And
Thank you.
what investigation for cardiac case, Dr. Amruta?
Yeah, actually, that even I don't know.
Just-
I think if I
we
get
are not
once I
aware
get the
of it.
feedback thing, I
The
can say what comments
standard
they've written.
investigations we can always say. But
Yeah, I
what
told
he's
the standard
expecting-
ones, but he was expecting something very special. And I don't know. This was the chief examiner was also there in this room with him. So
Sometimes it might be a simple pulse oximetry which he might be expecting.
maybe I'll once I get the feedback and there's some answer in that, I'll
Many
let
times
you know.
we talk about ECG echo, then he will say, I'm just expecting you to tell about pulse oximetry. Like that.
Yeah, I didn't say pulse oximetry, so maybe it was something related. I'm not sure.
For cardiac case, we can have cardiac catheterization as the one stop answer for many questions. In case
The
the
cardiac?
examiner wants catheterization. You know the pressure and all those things.
Yeah, probably.
Complex heart disease with dyspnea. Maybe that is one thing that will give an answer for most of the. That is the
Yeah,
final thing we will do. Maybe.
Yeah, I said that CTPA something related, but then he was like, okay, why? And then thankfully the bell rang. I ran out.
Okay.
Okay.
I was mentioning about cardiac catheterization. Somebody was asking me in the chat. Catheter studies to see the pressure gradients and the pulmonary hypertension part. All these things can be studied by direct catheter.
So maybe any other doubts? And Dr. Amruta and Dr. Rahul, what maybe final summarized advice you want to suggest?
I want to suggest all of those who are preparing, just make your own notes, which is crisp and clear, so that you can do the last revision and the last final day. And regarding this history as well as the development, you will be missing a lot of points if you are not making your own notes, and that format if you are not keeping. And also this communication, different types are there, information giving errors, all these have such certain points, we should not miss it. So before entering into that station, you can write down on your rough paper so that you are not going to miss any points. That's what I want to tell you.
Yeah, thank you. That's great. And Dr. Amruta?
I think practice, even all the clinical stations also with the dummy patient, practice with the time. Practice with 2.5 minutes, because that's all you'll get. You'll have to say hello, thank you, all of that. So, and do the stations also, development history. Unless you keep talking, you'll fumble. Even if you know it so well, you'll fumble from there, because it's a bit stressful when somebody is just staring at you and trying to assess you. So practice with somebody, peers, as much as you can.
So I think practice is the only way to clear this exam. So I think knowledge is there. Everyone, whoever has finished MD Pediatrics, everyone has the knowledge, but only the practice and how you are going to talk. And as you said, how you are going to examine when someone is staring at you. So, and you have to, for clinicals, there is no other option. You have to keep seeing cases. You have to keep seeing cases in that small amount of time. So put a time.
Put
5
stopwatch
minutes.
or timer and start practicing.
Start practicing. Even if it is not a case, still you assume, and at least the format you will be practicing. And if you see better, like I went to the tertiary setup monthly once to see the cases. If you are not exposed to cases, you can go to your tertiary setup where such cases will be there, and try to see. Because without seeing cases, clinical station will be very tough. And without practicing, all the other stations are going to be tough. So that's my.
Yeah, and one thing is, like, when they say, okay, they'll give you a clear command like respiratory or cardiac, always keep that format in your mind, how you're going to do it, and keep revising that format again and again and again, because only then you'll do it without, and they'll see whether you're fumbling, whether you're forgetting to do things, if you go back and do something else, all that they're sitting and actually noticing. So do it in that order, keep the order and do it.
And Dr. Sabri, you want to add anything? Closing note.
Thank you all for the spending time.
Thank you.
And it should be useful to other people who are going to
Just
appear.
want to add, the target group has helped us a lot in the short span of time. Both Harsha Madam and Balaji sir have taken sincere effort.
Yeah.
Thanks from the bottom
Yeah,
of
and both
both
of
of
us
us.
started
Yeah.
learning. I mean, started quite late, and we were just reading random things till then, and then we got a really structured approach to all the other stations only because of this target class. So thank you so much, both of you,
And they
sir and
adjusted
ma'am.
all the classes according to our requirement. I think we do have the
Both of
duties.
our duty schedules.
Thank you
Yeah.
so much. Thank you.
It was nice, actually. It was nice interacting with you. You both were sincere, and we are glad that we were of help.
Thank you, sir.
Thank you so
Every
much.
time, no, every time when we see someone is at needs some fine tuning, no, that 1.5 lakhs plus money only comes to my mind. Oh, they have put in the money, they should definitely
Yeah.
cross the line.
And
Too much money, actually.
it
So,
is. Yeah. And I got to know how bad Singapore is only after I spoke to you. I didn't know, but before applying, till then I thought, okay, another place.
So Singapore is kind of
Those who are taking Sri Lanka, I feel it as a good one. If you're practicing well, definitely you're going to pass.
Dr.
I think
Sabri.
both of you, I think even though last minute you got the format and you are quick to adapt to the format, that made the difference.
Yeah, like Santa. Thank you so much.
Thank you,
Thank
sir.
you. Thank you. And for others also, anytime we are in the group, you can contact us. Sabri.
All the best to everybody writing the exam in the coming
Yeah,
months.
all the best.
Thank you.
Thank you. Thank you.